Dr. Kenneth Thomas here with North Mississippi Urology. Let's say you have prostate cancer. What do you do now? What are your options? We're going to take a deep dive into this, and I'm going to try to explain every little caveat that we are thinking about as physicians, but we also want you to think about as the patient and as the family taking care of the patient. So, let's start out from the beginning. You had a biopsy, and with that biopsy, we took little needle biopsies of the prostate itself, and then a pathologist looked at those biopsies under the microscope. When they look at it under the microscope, they say, okay, is there prostate cancer here? And if there is, how bad is it? On a scale of 1 to 5, how bad is it? And then they say, what's the second most common number that we see there? And they'll take those two numbers and add them together. So you get a score somewhere between 2 and 10, if you think about it. Makes sense. That's called the Gleason Score. Now, with the Gleason Score, let's say you have what's called a 3+3, then we would call that a Gleason 6 prostate cancer. Let's say you have a 3 + 4 = 7, we would call that a Gleason 7 prostate cancer. Here's a trick. That's different than saying a Gleason 4 + 3 = 7 prostate cancer. For us, what that means on the urology side is we saw, or the pathologist saw, more 4s than they saw 3s. And so that's going to be a little more aggressive than what we call a 3 + 4, if that makes sense. So your urologist is going to talk to you about that Gleason score. And I'll tell you, what we see mostly are what we call Gleason 6s and 7s. We almost never see a 2, 3, or a 4. Sometimes we'll see a 5. And then we do see 8s, 9s, and every once in a while a 10. And that helps us figure out kind of part of the puzzle. Other parts of the puzzle that we're looking at as urologists are the PSA itself, that prostate number from the blood that they drew, and that's probably how you originally got to the doctor, was looking at the actual PSA number, and then that's probably how you got to eventually a biopsy. But we also look at several other things along the way, and most urologists, including us here at North Mississippi Urology, use what we call the AUA guidelines, American Urological Association guidelines, as well as the NCCN guidelines, National Comprehensive Cancer Network guidelines. Now, I know for sure that NCCN has a patient version of what we look at that I believe you can download, and it can help sometimes in answering some of these questions, which can be complex when you're talking about cancer, and especially prostate cancer. The AUA, I don't know if they have one that is for patients, but you could still, nonetheless, you could look it up. It's just called AUA guidelines. So, goals of care. When you're talking about prostate cancer, our highest goal is to address the prostate cancer, okay? The other two big goals are, we want to make sure that you can still, whatever we do, you can basically still pee well, okay? And it's not going to be to the extent that you have trouble peeing or to the extent that you have leakage, okay? We want it to be where you're able to void well. The other thing is we want you to have at least, hopefully, the erections that you have before surgery. Now, I say before surgery because I want to make the big point that some people, when you get to talking about this, they may get back to baseline after whatever procedure they have done to address the prostate cancer, but their expectation for erections is higher. But it has to be where you are at your baseline before surgery, not when you were 20, okay? Honestly, as guys, We all wish that, but that's just not how it is at that point in life sometimes. So we just have to deal with what we have and what we can work with. Now, when we're looking at options, there are just a few big options. Depending on when the urologist is looking at all of these different things like the PSA and your Gleason score and stuff like that, we will then say, okay, depending on those results, active surveillance could be an option, which means we know prostate cancer is there, but we, in talking with the patient, have come to an agreement that with comparing risk and benefit, we think that that is a reasonable option moving forward. Okay? Second option is surgery, which today most of the time means robotic surgery, which means tiny little incisions on your belly, and a urologist would take your prostate out basically, and then that would be that. You would usually stay in the hospital at least overnight. You would have a catheter in for at least 7 days, probably up to 10 days. Again, just depending on the protocol for that specific urologist. And your third option is radiation. There's two different types of radiation that are mainly used. One is called brachytherapy, and basically, if like this is your prostate, it's putting tiny little seeds of radiation in the prostate, and that is an option for a lot of people. A second option with radiation is what's called external beam radiation therapy, and that's where, again, if this is your prostate, then from the outside for about, we'll say, a month, they can put radiation that would come through your body and just work on the prostate. Okay? It's kind of like magic, but there is a little bit of a scientific whatever, to it, and we know what we're doing, and it tends to work really well. Now, I did forget to say with the brachytherapy, one benefit to it is it's what I call a one and done, in that you would go into the hospital to get that done, and a lot of times you'll go home the same day. One thing that we do here at North Mississippi Urology is no matter what kind of radiation you have, if that's what you choose with your urologist and in discussion with your family as well, then we will actually put a spacer in between. We'll say this is the prostate and this is the rectum or the colon. They sit right there on top of each other. So we actually at the same time will put a little spacer in between them so that you don't get radiation down here to the actual colon, and then that will just disintegrate and your body will, for lack of a better way to explain it, eat it back up over time. So that goes away. So we've talked about active surveillance, we've talked about surgery, we've talked about radiation. Another big option, again, depending, is what's called androgen deprivation therapy, or we will call ADT. There's several different ways to do that, and a lot of it is some combination of a pill and or a shot that you take every so often. And this is the way that I explain it to patients, is it's not going to get rid of the prostate cancer, but it's like if the prostate cancer was a plant or a flower, it's taking the water and the sunlight away from that plant. It will shrivel up, but the plant itself is still going to be there. That's not necessarily a bad thing. It just depends on where you are as far as how advanced your prostate cancer is. There are other options for treatment, including cryotherapy, which is freezing the prostate, and high intensity focused ultrasound, which is called HIFU. And even past that, there are some other options. For those, I would say at this point, for the cryotherapy, it tends not to be used as much these days compared to some of the other options, because some of the other options have a lower risk and lower what we call morbidity, which means basically kind of like your side effects long term after you're treated. And HIFU is still kind of new, even though it's been around for, I'll say, about a decade. And we just don't have enough good data to strongly support it being as good as some of those other options that we talked about. Now, when we're using, as urologists, the NCCN guidelines and the AUA guidelines, we're looking at, okay, what's going to give the best outcome for you as the patient? And when we say options, it's a good and bad thing in that a lot of these options, the long-term results are the same when we look statistically. Especially, for example, if you look at surgery versus radiation, again, depending on your scenario, the results long-term may be the exact same. So then, for better or worse, it comes down to a patient preference. So hopefully, in this little explanation, I've given you at least some background to be able to ask some educated questions and be able to have an opinion on how you want your prostate cancer treated. At the end of the day, know that your urologist is going to take care of you, and they are going to treat you as if you were their dad or their brother. This is Dr. Kenneth Thomas with North Mississippi Urology. We'll see you next time.